Hello everyone, good day wherever you are on the globe. My name is Zeev Shoham and I'm the Medical Director of the IVF unit at the Kaplan Medical Center in Israel and co-chairman of the IVF Worldwide Education Platform. It is a pleasure to serve as the moderator of this webinar. The topic of today's webinar is Fresh and Frozen, When and Why. This topic is a controversial one, and therefore we would have three distinguished speakers who will discuss the topic. Our first speaker is Professor Wang from Vietnam. She is the head of the Department of Obstetrics and Gynecology, University of Medicine and Pharmacy at the Ho Chi Minh City. The second speaker is Professor Juan Antonio Garcia Velasco, who is the director of IVI Rama, Madrid in Spain. And our third speaker is Professor Laura Rinzi. She is the laboratory director of the Ginera Centers for Reproductive Medicine in Rome, Marsotica, Umbertide, and Naples, Italy. You can see here the speaker's disclosure. And the agenda for today is as follows. We will start with the background given by Professor Wang. We then will move to the current evidence for freeze-all system with Professor Garcia Velasco. Then we will have the cons about freeze-all by Professor Wang. We will hear about the embryologist perspective from Professor Rinzi, and we have conclusions from Professor Garcia Velasco. And then we will have question and answer. We will try to answer your questions if the time permits so. And without further delay, we'll start the program, Fresh and Frozen, When and Why. So Professor Wang, the stage is yours. Please go ahead.
Ladies and gentlemen, I would like to give you some background on freeze-all. Traditionally, fresh embryo transfer is performed in IVF. However, there are some concerns related to IVF fresh transfer. The first one is the ovarian hyperstimulation syndrome. It occurs in about 1 to 5% with the moderate to severe stage, and rarely there are some deaths. The second one is the poor obstetric and perinatal outcomes. With the use of GnRH agonists for triggering maturation, the OHSS rate has been reduced significantly. However, in agonist triggering cycles, which use HCG for luteal phase support, OHSS is still occurred. It occurs in about 4.4% with a severe rate of 0.72%. So how about agonist triggering cycles without the use of HCG for luteal phase support? Still, there is about 0.3% of cases get severe OHSS. Therefore, Professor Paul Defroy was the first one who suggested a new regime to eliminate ovarian hyperstimulation syndrome, which is the agonist trigger combined with freeze-all. And his idea is that can we have an OHSS-free clinic by segmentation of IVF treatments? The second aspect is about the obstetric outcomes of the fresh embryo transfer. So for a long time, studies have reported that the fresh embryo transfer resulted in the poor obstetric and perinatal outcomes. So Shapiro was the first one reported that freeze-all seems to have better obstetric outcomes in normal responders and high responders in his randomized control trials. With the evolution of vitrification, the ongoing pregnancy rates per cycle significantly increase with vitrification as compared to slow freezing. So, in combination with the vitrification method and also the improvements in the very first few studies in freeze-all compared to fresh embryo transfer, there was a bunch of papers discussing about the use of freeze-all in IVF. In fact, in 2014, there was an issue in Fertility and Sterility discussing a lot about the use of routine freeze-all in IVF. So despite now the use of freeze-all is still discussing under the way, there's a trend everywhere in the increased use of frozen embryo transfer freeze-all. This chart shows the increased use of freeze-all in the United States, as you can see here, with different classifications of ages of the women. All the freeze-all cycles has been increasing over the years. And the same trend is observed in Germany. From 1995 to 2019, the number of cycles with freeze-all and frozen transfer has been increasing. So the idea of routine freeze-all. Should we do routine freeze-all in IVF? So the pro for freeze-all is that freeze-all might improve pregnancy rates and reduce ovarian hyperstimulation syndrome, facilitate single embryo transfer, minimize pregnancy complications, and improve neonatal outcomes. But the cons for routine freeze-all policy is that is there enough evidence to support the routine freeze-all policy? So how is the efficiency of the freeze-all? How is the cost effectiveness of freeze-all? And how is the time to pregnancy of freeze-all policy? Now, let us go through the evidence.
Thank you very much. It's a great pleasure to be in this webinar today discussing about freeze-all, something that has gone like a pendulum from one side to the other. And I think today we have enough experience to see what are the benefits and the cons of the freeze-all, and we will see also some other points of view. So basically, as we know, implantation is a delicate equilibrium between embryo quality, which is the main player, and the metal receptivity that we are starting to understand a little bit more, and transfer efficiency and how optimal we can transfer this embryo inside the uterus. So even though this is not an equilibrated balance, because the main player is the quality of the embryo, and the metal receptivity, we know it's distorted by ovarian stimulation, and this changed in the past some of the ideas, such as to consider freezing all the embryos and transferring a natural cycle, considering that it could be better and you could get better implantation rates. In fact, in 2013, this paper was published as this was one of the big hypes at that time. Should we freeze everything and never do a fresh transfer anymore? So it became like an embryo frozen fever in all the ART units and hospitals. And we were waiting for the data, because one thing is the concept, the biological plausibility, but then we need data to support that. And we realized that some of the studies, one of the largest studies coming from China with Dr. Legro also as a co-author, was published in the New England Journal of Medicine, showing that it could be beneficial in some patients, but not in ovulatory patients. And more recent data from BMJ in 2020 published this year in the group of Anya Pinborg, showed again that maybe it's not good for women with regular menstrual cycles. Maybe it could be good with an indication, but not globally to every patient. So basically, we will briefly discuss the elective and non-elective indications. Elective indications is that we need to freeze because we have to freeze. For instance, when we do biopsy of the embryos, PGTA, we need to wait for the outcome of this biopsy, so we need to freeze the embryos. Of course, in fertility preservation, when we're doing oocyte or embryo pooling in poor responders or in any other condition. So here, there's no options, we have to freeze. However, the non-elective indications is not needed, but maybe improve the outcome. And this is the risk of OHSS that we can handle and manage much better today. The issue of high progesterone at the end of the follicular phase, embryological reasons that will be discussed also by the embryologist, Dr. Laura Rienzi, some tubal or uterine factors, and maybe recurrent implantation failure. One of the non-elective indications that we face, and we can improvise even along the stimulation phase, we may schedule from the beginning, but sometimes it does happen along the stimulation, is to freeze the oocytes or the embryos because we have a response that we didn't expect. And we know that when you freeze the embryos and you do an elective frozen in the next subsequent cycle, you reduce dramatically and significantly the risk of OHSS, as shown by Roque in this meta-analysis published in Human Reproduction Update last year. And we know also that the implantation rate is going to be more or less the same. There was some controversy in the early studies in 2010, 2011. Today, we see that this forest plot crosses the unity, so it is non-significant different what we can see here. So it's going to be exactly the same outcome whether you freeze or not, but you're going to have a safer outcome with the patient without any risk of OHSS. However, if we talk about polycystic ovaries, and these are women at high risk, as we know, developing too many oocytes, we have this paper from Chen, again with Dr. Allegro as co-author from China, showing that if you transfer fresh, you have a 42% live birth rate, as you can see in this graph, adapted from the data of this paper. However, you freeze the embryos and transfer later, you have a significantly higher live birth rate. And this may be due to the compromised endometrial receptivity. So again, in women with high risk of OHSS, with women with PCOS, may be interesting to freeze and transfer later. Similarly, when we have an elevated progesterone level at the end of the follicular phase, we know from years ago, the works of Filippo Baldi and others, that when you stimulate the ovaries, your endometrium is going to change. And if you take a biopsy at the time of the trigger, you will have advanced endometrial maturation, which could be due to this supraphysiological level of esteroids. You have huge amounts of esteroids, estradiol and progesterone in circulation, and this is going to induce morphological and biochemical alterations. Because we know that even in the best quality of embryos that we may get, the best and the most beautiful blastocysts, which is even euploid after PGTA, 2 out of 3 will become a pregnancy, but 1/3 of these euploid embryos do not implant. So something may be wrong in this endometrium. And we know from 10 years ago, and the works of Ernesto Bosch showed that after a certain threshold, this progesterone at the end of the follicular phase, when it crosses this threshold, your pregnancy rate is going to drop. It's not going to be 0, but you're going to have a significantly lower pregnancy rate if your progesterone goes beyond 1.5, 1.8 nanograms. If you look at the endometrium here, when you have a high progesterone, you can see in this heat map how if you have a low progesterone, this is the gene expression. If you have a high progesterone, you have a completely different picture. Even without having any clue about molecular biology, you can really see how different this gene expression may be when progesterone goes beyond the threshold. So the question could be if this high progesterone is affecting your oocytes or your embryos, or maybe it's affecting the endometrium. And it is clear that affects the endometrium, as I showed before. And even though some works may suggest that it could be affecting the embryos, most of the studies that have been published so far show that the impact of this progesterone is on the endometrium. It's not going to affect this progesterone, elevated progesterone, nor the oocytes, nor the embryos. So it's a matter of endometrial receptivity. This is data coming from a study done by Dr. Lan in Vietnam. Again, women at risk, non-PCO women. And here you can see in this nice analysis how If you have a high progesterone, you will have lower live birth rate. If you have low progesterone, if you have high progesterone, patients are going to do better if you freeze. Like you can see here, progesterone in this fourth quartile, beyond 1.5. If you do freeze only, your pregnancy rate is going to be higher. Same also when it's beyond 1.1. However, you have low progesterone, there is no benefit in freezing. Even it could be even worse if you freeze at this stage. So again, you have to have a threshold in your unit. There's no universal cutoff. We use 1.8 nanograms. I know some units use 1 nanogram, some others go up to 2. You have to check your data, but there's a certain threshold where you will benefit your patients in blue that may benefit from freezing. But if you try to freeze to everyone, you may even do some damage to these patients. As I mentioned, the threshold is not universal. We know that the lower the progesterone, the better, the higher, the worse, but we have a threshold of 1.8 nanograms. And again, it's going to be slightly different whether it's a poor responder or a high responder. High responders tend to tolerate high progesterones better than poor responders. So the worst outcome could be a poor response with high progesterone at the end of the follicular phase. And it's not only how high this progesterone goes, but also for how long you have progesterone exposure. This is a study from Lee et al. A few years ago, and they saw how the clinical pregnancy rate was compromised according to the duration of this elevated progesterone in the follicular phase. If it was very short, just 1 or 2 days, or if it was more than 2 days, you can see a clear decline in clinical pregnancy rate, ongoing pregnancy rate, and as expected, because you may have a slightly high progesterone for 4 days, and this is much more deleterious than maybe have a very high progesterone for just 1 day when you are about to trigger. What about the embryo? Well, it will be discussed later by Dr. Rienzi, but our group from RMA New Jersey published this paper with Dr. Farnese as first author, and he saw that when embryos are slowly cleaving, they may be asynchronous with endometrium, and you have this problem that when you transfer fresh, if it's a slow embryo, you have, as you see in blue, a lower pregnancy rate than if you have a normal cleaving embryo in red. However, if you freeze these slow cleaving embryos, the blue ones, and you transfer them in a frozen embryo transfer, there's no difference whether it's a day 5 or a day 6 embryo. So that means that maybe this asynchronous time between the endometrium and the embryo could be solved by doing it in a 2-step approach. You freeze your embryos, you transfer later. There's some issues that may happen and appear during the stimulation in the endometrium or even in the tubes. Obviously, we have to do a detailed pelvic ultrasound before initiating the ovarian stimulation, but sometimes we know that everything is fine in the previous scan, and then suddenly you may find a hydrosalpinges that could be empty before, and with the secretions of the stimulation, they become full. Suddenly, small polyps may appear, or even the endometrial thickness may not be as thick as we expect, and then we decide to freeze and not transfer in this cycle. Again, non-elective indications. And what about recurrent implantation failure? This was a hypothesis coming from this paper from Magdi in FNS in 2017. They analyzed 171 women with recurrent implantation failure with previous failed cycles of 3.8, so difficult patients. Mean number of embryos transferred 2.2, so high number of embryos transferred compared to today's standards. And what they found is that ongoing pregnancy rate was significantly better after freezing the embryos rather than transferring fresh. So to conclude, I think we have clear non-elective indications for freeze-all, which are the risk of developing OHSS that we can handle today with agonist trigger and freeze, the accumulation of progesterone at the end of the follicular phase, abnormal endometrium, an embryo endometrial asynchrony. However, recurrent implantation failure data needs to be replicated as it is not clear as it may seem. And again, as I mentioned before, we sometimes change the way we practice before definitive evidence is obtained. And this is why we meet in meetings like today. We meet here to question the evidence and make clear conclusions to improve the care we provide to our patients. Thank you very much.
Hello again. For Professor Juan Velasco, I'm debating on the issue fresh versus frozen transfer in IVF-ICSI, and the motion is con of freeze-all. So freeze-all is not for all. I must say that yes. So in the next few slides, I would like to show you to prove why I say yes for freeze-all is not for all. So in with the emotion, I'm sure all of us think that fresh means something good. Fresh food, fresh fruit, fresh meat, fresh milk, fresh water, fresh air, and fresh face. When I looked at the dictionary, it says that fresh applies to what has not lost its qualities. So for the emotion, it's like that. But how is the evidence-based medicine? So what is evidence-based medicine? It's the common part of scientific evidence, of patient values and clinical expertise. So now let me go through with you the 4 aspects of the available evidence of fresh transfer versus freeze-all. The efficiency of freeze-all, the safety, the cost effectiveness, and the time to pregnancy. So let's go through the first aspect of the debates, which is the live birth rate. I think all of us are aware about this study. It was the first RCT comparing fresh versus frozen embryos in women with polycystic ovary syndrome. It says that the live birth rate was significantly higher with freeze-all as compared to fresh transfer. And in this study, the authors used day 3 transfer. So how about other types of women? Ovulatory women, day 3 transfer. Another RCT also performed by the same group of people. It says that the live birth rate was similar between freeze-all and fresh transfer. Our group published an RCT in the same issue in the New England Journal of Medicine. We compare fresh transfer versus frozen transfer in ovulatory women, day 3 transfer. We found that the live birth rate was similar between freeze-all and fresh transfer. So how about for the blastocyst transfer? It says that live birth rate is better with freeze-all as compared to fresh transfer. So over another paper also compare freeze-all versus fresh transfer in ovulatory women using blastocyst transfer. And it says similar pregnancy live birth rates between freeze-all and fresh transfer. So it seems that data on ovulatory women with blastocyst transfer is still very controversial. And in a recent study published in Human Reproduction very recently, it says that in more than 25,000 donor cycles, the recipients had similar live birth rates between freeze-all and fresh transfer. How about the meta-analysis? The 2 most recent meta-analyses shows that the live birth rate after the first embryo transfer was higher in high responders or PCOS women, but no difference for normal responders or the non-PCOS women. So another meta-analysis also showed the same figures with high responders, freeze-all is better, but with normal responders, freeze-all is similar to fresh transfer. So again, freeze-all is not good for all in terms of live birth rate, in terms of the efficiency. So now let's go to the second aspect, which is the safety of fresh transfer versus freeze-all. We all aware about the risk of hyperstimulation syndrome in the fresh transfer in IVF. So we thought that with freeze-all, it should eliminate the ovarian hyperstimulation syndrome. Is it true? As you see here, only OSSS rate is lower with freeze-all only in PCOS women or in some paper. But the OSSS rate is also similar in other papers, especially in normal responders or non-PCOS women. How about the obstetric and perinatal outcomes? So in a meta-analysis, shows that the risk of freeze-all versus fresh transfer is that the freeze-all, the frozen transfer, increase the risk of hypertensive disorders, increase the risk of large gestational age, and increase the risk for high birth rates. So we're thinking that is there any problem with the placentation in the frozen transfer cycles? Or is there any epigenetic issues with the babies born from frozen transfer? We're not sure about the safety of the children born after freeze-all yet. In a long-term follow-up of the babies born after freeze-all versus fresh embryo transfer, our group have reported that the ASQ3 problem-solving score was significantly higher in children born after frozen transfer versus fresh transfer. However, all other ASQ3 scores and all reflex questionnaire parameters were comparable between two groups of babies. And when we say about freeze-all, we must think about other long-term risks of the technical issues as well. For example, if fire occurs, if the electric power is shut down, or if natural disasters occur, such as earthquake, flood, tsunami, there will be a big problem for freeze-all. Now, let's go to the cost effectiveness of fresh transfer versus freeze-all. In a paper published by our group, we found that the cost per live birth for freeze-all was about 8,000 euros. Meanwhile, 7,400 euros for the fresh embryo transfer group. So, the freeze-all is not more cost-effective than fresh transfer. How about the time to pregnancy? As a couple coming for IVF treatment, what they want is that they want pregnancy, they want baby with the shortest time as possible, as much as possible. So with fresh transfer, the time to pregnancy is significantly shorter as compared to freeze-all. That's about medicine. So how about movie, the real life? I think all of us know and love the Disney movie Frozen. So what happened to the frozen girl the Elsa. By accident, she was frozen, and the end of the movie was that she became fresh, and everybody in her hometown was so happy. So everything was the way it's supposed to be. I must say that let's do fresh transfer as the way it's supposed to be. So once again, I would like to say that freeze-all is not for all. Yes. Thank you very much for your attention.
So first of all, I would like to thank the organizer to have invited me to make this presentation on a very important topic, which is fresh versus frozen embryo transfer and the embryologist perspective. I mean, it's very important because it's the embryologist who is doing the vitrification, the cryopreservation. So our perspective is really important in this story. So this is my declaration of conflict of interest, nothing related specifically to this presentation. Cryopreservation is really essential in IVF. It has been really a revolution because if you have an efficient cryopreservation program in your setting, you can enhance the cumulative live birth rate per patient. So you can use supernumerary embryos and make additional transfer, and in this way increase the chance to have a baby per cycle. And this is really very important for our couples. You can also reduce the number of embryos to be transferred at the same time, because of course, if you trust your cryopreservation program, you will be more prone to transfer one embryo at the time, reducing the multiple pregnancy, increasing the safety of our treatments. It also provides the opportunity to do freeze-all or cycle segmentation. But for embryologists, it's also increasing the time that we have to assess the embryo quality, not only from a morphological point of view, but for any other technique that may be used in IVF in the future. Of course, when we cryopreserve the embryo, we have extra time to make any kind of evaluation. So this is a great opportunity for the embryologist. But I have to underline also that an efficient cryopreservation program allows also more patients to access to treatment. When we think about fertility preservation, because we are today able to efficiently cryopreserve oocyte, many patients, many women all around the world can preserve their fertility for medical, specifically, or non-medical reasons. And it also enables to create egg bankings and bank. And this means that oocyte from donors can be cryopreserved in one country and imported in another country where, for legislation or for any other reason, we have less donors. So this is an incredible opportunity, and it higher the access of patients to treatment. And we are very proud as embryologists to have set such a program with so many opportunities for our patients. But it has been difficult. It's not so easy to cryopreserve embryo, and specifically, it's difficult to cryopreserve oocytes. Today, we know from the data, this is our systematic review published on Urine Production Update, that vitrification is the most effective technology to cryopreserve any stage of development, from oocyte to blastocyst. And because the survival is increased, is optimized, of course, in turn, the clinical results are better. In this slide, you can see that survival rate today is so high. It's unbelievable how efficient we are in the lab today to cryopreserve embryos. As you can see in this meta-analysis, the survival rate range in the different studies between 85 to 100% for any stage of development, 2P and cleavage stage blastocyst. And it's also very interesting to see that all the studies are in favor of vitrification as compared to slow freezing. This is why I can really state that vitrification is the most effective technology to cryopreserve the embryos. It's also very interesting to see that oocyte can also survive very well. But we were a little bit scared when we started oocyte cryopreservation for the specific sensitivity of this cell, in particular related to the presence of the meiotic spindle. So we were scared by introducing vitrification of the meiotic spindle, we could affect the subsequent chromosomal segregation, increasing aneuploidies in the deriving embryos. But in this beautiful study, it has been shown that the risk of aneuploidy is similar between fresh oocyte and vitrified oocyte. So this is a safety issue, and it's really very important. Now, also, we have to be sure that long-term effect on embryos and babies. And we have different studies that has assessed the efficacy of cryopreservation according to the time of storage that are really reassuring, especially neonatal outcomes. Babies seems to perform in the same way if they derive from short-term or long-term cryopreservation. But in the last study published by a group of Shanghai in neuroreproduction, the efficiency of cryopreservation seems to be affected by the time of storage. It means that longer the embryos are in nitrogen, less efficient will be the technology when looking to implantation and delivery rate, although the neonatal outcomes are the same. It means that still there may be, and we have to explore this better, there may be some degeneration effect of long-term vitrification, especially for cleavage stage and less, it seems, to blastocyst stage. Now, for embryologists, to cryopreserve so many embryos for so many indications, it means a lot of work in the lab and a lot of technology and a lot of investment. This is a picture where you can see how many tanks are needed today to cryopreserve embryo. In Italy, we have to cryopreserve the embryo forever. We cannot destroy embryos. We cannot donate to research or donate to other couples. So imagine the capacity, what we need to have in our labs and how much time it is invested by the embryologists to perform vitrification, but also to make a safe storage, a long-term storage for our embryos. So this is for sure a drawback. Now, let's look to the efficiency and the opportunity that vitrification gives to our patients. I don't think that we can be pro or against cryopreservation, because in the majority of the programs, especially in single embryo transfer program, which is the gold standard today, the two technology will be combined. The first embryo may be transfer fresh, but then the second and the third will be transfer cryopreserved. And this is super important because, of course, it's increasing the cumulative live birth rate. So we have to explain to the patient that although they go through a fresh transfer, they may also have additional embryos for cryopreservation, and the two technology will be combined. As you can see, when you have about 10 or 15 oocytes, the chance to make a cryo cycle with surplus embryo is about 50 to 60%. So it is really very important. This technology is really adding a lot to our cycles. We have performed a study with the Italian registry based on cycle-based data analysis. And we have realized that even in a country like us, where cryopreservation of embryos was not allowed by law for many years, since it has changed, now we can cryopreserve embryo, but with some limitation. The contribution of a surplus cryopreserved embryo to the cumulative live birth rate is incredibly high. It's about 40% for any age of the patient. So imagine that you have a 41 years old woman, she will have 88.3% as a mean live birth rate per cycle, but by using the surplus embryos when available, we can reach 13% live birth rate with a relative contribution of about 40%. And this is true for any age population. And of course, more are the oocytes available, more will be the contribution of cryopreservation to the cumulative live birth rate. Now there is some disclosure, some discussion about how many oocytes are needed to optimize the cycle. I'm not going to discuss about this. This is a clinical aspect, but it's important to underline that today we have enough data to say that the number of oocytes retrieved and the response to the stimulation is not going to affect the blastocyst formation and the euploidy of the deriving blastocyst. So from an embryological point of view, we don't see the difference if the oocyte come from a small cohort or a high cohort. we don't see the difference when we try to evaluate the quality of an embryo. It's very difficult to evaluate the quality of an embryo because an embryo, it's a puzzle of different aspects. And it's not just looking by morphology, but we can understand if the embryo is viable, able to have mitotic activity, reach to blastocyst stage. We are not able, by looking to an embryo, to know about the genetic content of the embryo, but not only the chromosomes, but also many other genetic aspects of the embryo that need to be better explored to understand and to predict the implantation potential of this embryo. And specifically, we have no information about the capacity of the embryo to implant into the uterus, what I call the competence of the embryo. So it's very difficult to assess an embryo by just looking at it. What we know today is that if we transfer in a good prognosis population of patients a fresh day-free embryo, the live birth rate expected is about 25–30%. But if we extend the culture to blastocysts, we increase our prediction on implantation, and we can reach 37% live birth rate per single embryo transfer. Of course, if we have the opportunity to cryopreserve the embryo and extend further our embryo assessment by introducing, for instance, the chromosomal status of the embryo, we increase our prediction on live birth to 50–65%. So from an embryological point of view, to be able to stop the time and make additional, as I said, additional evaluation on the embryo, it's a great opportunity to better predict live birth. And this is true for all patient population, especially advanced maternal age, where, of course, chromosomes affect even more the quality of the blastocyst. So by having the opportunity to assess this aspect, we can increase our prediction on live birth rate. Now, from an embryological point of view, there is another important aspect to underline when thinking about fresh versus cryopreserved embryo, is the rescue of slow-growing embryos. There is about 30% of the embryo that are at molar stage on day 5. And if we transfer this embryo on day 5, we don't know if the embryo are real blastocysts because they are still at molar, and the implantation rate is the blue bar. As you can see on day 5, fresh embryo transfer, we have a lower live birth rate per transfer. On the contrary, if we postpone the transfer to day 6, then we assess the quality of the embryo. So in that case, we are going to transfer only blastocysts. We increase the live birth rate, but still the live birth rate will be lower as compared to normal growing embryos. So as you can see, the blue bar in day 6 fresh embryo transfer is lower in both young and advanced maternal age population. But if we cryopreserve this embryo at the blastocyst stage, we are sure that they are blastocysts, and we transfer them on day 5 post progesterone, then we will completely rescue the implantation potential of this embryo. So from an embryological point of view, cryopreservation allows to better synchronize the blastocyst developmental timing and the endometrium. So to conclude, cryopreservation is really essential today to optimize every single aspect of the IVF. And today we know that this has to be performed by vitrification. When I say we optimize the cumulative live birth rate per patient. We are able to transfer one by one. And if we have surplus embryo after the pregnancy has been obtained, we have also the chance to have a second child for our couples, which is very important when we think about family planning and not only a single baby. Elective single embryo transfer is really the goal, and it is really already, I would say, used for a good prognosis population. But for advanced maternal age population and worse prognosis patients, we still transfer more than one embryo all around the world, inducing multiple pregnancy and more risk for our babies. So this is why vitrification is such an opportunity to increase our prediction on implantation, has more trust in the embryo that we transfer, and in turn, we are going to transfer one single embryo for any kind of patient population. And it's also give an opportunity to rescue slow-growing embryos, which is very important from an embryological point of view, where we really want to have a chance for all the embryos to be transferred. On the other side, vitrification has a lot of requirements. We need a specific training. Vitrification is not the same in every single lab. We have huge difference in survival. We have huge difference in efficiency of the vitrification procedure. There are different protocol applied. We need to have standardized technology. We need to have a lot of technology in the lab that allow us to perform this technology vitrification in the best way, consistent and standard everywhere. And of course, we have to calculate that vitrification today is a lot of time invested by the embryologists. I would say that today, most of the time invested by embryologists is on vitrification and warming. So it means additional personnel and additional costs. So we have to put in balance all these aspects. Thank you very much for your attention. And I would like to thank, of course, all the group, General Life, for the different countries, from the different countries in Europe. And thanks, Ferring, for the invitation.
So after these different presentations with great speakers and great topics, I think it's time to conclude and to summarize all the evidence that has been presented today with some take-home messages that will help us to improve our patient care. First of all, we thought that by freezing we could improve pregnancy rate, we could reduce hyperstimulation syndrome, facilitate single embryo transfer, maybe minimize pregnancy complications while improving neonatal outcomes. And using this approach as a routine, maybe is not enough evidence yet to support this policy. And of course, we question about the efficiency, the cost effectiveness, and the time to pregnancy. I think after listening to the presentations today, I think freeze-all will not improve pregnancy rate as a rule. It's not something to use in all patients. And in fact, as shown by the paper of Dr. Lan, it may even compromise pregnancy rate. So we have to find an indication, otherwise it's not a good idea. Reducing ovarian hyperstimulation syndrome, I think, is quite clear. And we all agree that when we have a patient at risk today, it's significantly better to freeze oocytes or embryos and transfer later. Facilitating SAID, it's questionable because I think it doesn't relate to the freeze-all approach. I think it's a matter of quality control in your units, and I think is where we should aim, especially in young women. Minimizing pregnancy complications, again, is not clear the evidence that we have today, and improving neonatal outcomes. It could be in some of the neonatal outcomes that we have seen today, but not in all of them. In fact, some of them are worse when it's a frozen embryo. So it's not clear that freeze-all could help in the last three ones. So if we think about using routine freeze-all for all the patients, I think there's not enough evidence to support this policy. If there's no indication and the patient is not at risk, but we should not consider freeze-all as a routine. And if we think about efficiency, cost effectiveness, and time to pregnancy, again, it doesn't seem to be cost effective. It's not going to shorten your time to pregnancy, just the opposite, and is not more efficient. So I think the idea to use this approach as a routine to all patients is not probably the best one. But if you have an indication, of course, it's a great option. And if we talk about elective indications today, then I think we all agree that we need to freeze when we're going to biopsy the embryos. We need to freeze if we're going to do fertility preservation. And of course, we need to freeze when we do embryo pooling or oocyte pooling in poor responders. However, in the non-elective indications, I think OHSS is clear that the evidence will help us. It will help us to improve the outcome also if you have high progesterone, especially if it's for more than 2 days at the end of the follicular phase. It's going to help us synchronize the slow cleaving embryos. If you have an embryo that becomes a blastocyst on day 6, probably it's better to freeze and transfer next month. It's clear that we should freeze in women who have either endometrial or tubal or uterine factors, as we discussed today, not enough thickness, some fluid in the tubes, or maybe some polyps that appear during the stimulation. However, it's not so clear that freeze-all is a good approach in recurrent implantation failure patients. Regarding the lab, I think Laura Riench explained clearly that it's going to require specific training. I think vitrification is significantly more delicate than old school freezing or slow freezing, as is what called before. I think we need to be very specifically trained for this very subtle technique. We're going to need this technology and a space in the lab because we're going to end up freezing a lot of embryos, and we're going to need technology and of course, money, because we have to invest money in the lab, and we have to have not only the skills, but also the tools, the equipment, and of course, the nitrogen tanks. And this is what we wanted to discuss today. Thank you very much for connecting to this webinar, and I hope you found it useful. Thank you.